This lecture is going to examine looking at targeting the epidermal growth factor receptor, which is a tyrosine kinase. So EGFR is a lucrative pharmacologic target because overexpression of this protein/receptor leads to the activation of a really important signal transduction pathway in oncology called the MAP kinase PI3K-AKT pathway. These pathways really kind of converge a lot of the major cancer hallmarks that we associate with growing tumors. Angiogenesis, replicative potential, growth promotion, and evasion of apoptosis. These are the major players of this pathway. And it's a very complex pathway we don't really need to get into for this case. I think we'll save it for one of the oncology cases, and even then we'll go through it kind of superficially. But EGFR as a molecule or as a protein target is found in about a quarter of breast cancers. And another name for that, and Dr. Sasabo in her lecture had talked about the nomenclature, the HER2-neu is another name for that. So the HER2-neu mutation, at least in the breast cancer patients, is associated with poor prognosis. But from a pharmacologic standpoint, this is really kind of a good molecular target for us because the normal cell typically expresses around 20,000 receptors of the HER2-neu. These cancer cells express upwards of 1 to 2 million receptors, and so having a pharmacologic target that binds to, blocks, and inhibits its activity is going to be pretty powerful. So there's two targeting approaches that we can use. One is to use a monoclonal antibody. So this is a recombinant IgG, whose main mechanism is ADCC. Recall that's the antibody-dependent cell cytotoxicity. And then another smaller molecule, and that's what they're called, small molecule tyrosine kinase inhibitors. These are smaller organic molecules that actually fit into the receptor and block its activity. So the first group of drugs is protein in nature, and the second group are your classic kind of small molecule organic compounds. So trastuzumab, which is the brand name Herceptin, binds to the HER2-neu with high affinity, and this is of course a monoclonal antibody, and this is produced in mice, of course, and it's partially humanized so that the immune system doesn't attack it. But it is an immunoglobulin, and basically what it does is it binds to the HER2-neu positive cells and basically tags them for antibody-dependent cell cytotoxicity. Trastuzumab is a great drug. It's the standard of care for patients with EGFR positive or HER2-neu positive breast carcinomas, both early and advanced breast cancer that have lymph node involvement. There also is a HER2-neu mutation associated with gastric tumors, which you'll learn about at some point. Trastuzumab can also be given to those patients. And trastuzumab is often combined with classic chemotherapeutic agents for these cancers. And by classic chemotherapeutic agents, I'm talking about cisplatin, doxorubicin, those types of compounds, which you'll learn about in oncology. The side effects or toxicities associated with trastuzumab include infusion reactions, of course. This is immunoglobulin, so the patient can't swallow it. It'd be immediately denatured by gastric acid, so this is something that has to be injected into the vein. And of course, within that, there are stabilizers and other compounds that keep that immunoglobulin molecule well preserved. And so the infusion reaction is to those stabilizing molecules. It's not necessarily to the immunoglobulin itself. So fever, chills, nausea, and vomiting, that's all associated with the aqueous environment that the infusion compound exists. These drugs are teratogenic. Epidermal growth factor receptor is found on a growing embryo, and it's involved with different promotions of growth in different phases of embryogenesis. And so patients that can or will become pregnant cannot take this. Trastuzumab is also associated with heart problems, especially when combined with the classic chemotherapeutic drug class, the anthracyclines. There's a black box warning. When you combine those two drugs, you have to do some echo or some other cardiac measurements to basically ensure that the patient has normal ventricular ejection fractions. There are some lung manifestations and toxicity. There's a group of epidermal growth factor receptors associated with lung physiology. And so you can see some lung side effects. And of course, low white blood cell counts are also associated with this drug. The other antibody that we can use to block HER2/neu is pertuzumab. This is a monoclonal antibody, and this is indicated for early and metastatic breast cancer. Pertuzumab is a different molecular target on the same HER2/neu. So we can actually combine trastuzumab with pertuzumab with classic chemotherapeutics like taxanes or anthracyclines. And of course, this antibody as well is embryo lethal and can also be heart damaging. And so you have to check the patient's left ventricular ejection fraction before, during, and after infusions with that drug. Now, the small molecule tyrosine kinase inhibitors, such as lapatinib, these are orally active, so these are very small compounds that get biotransformed by the liver and so forth. They're orally active for breast cancer and other solid tumors. These also target or silence the HER2/neu EGFR pathway, and we can combine these with the other drugs. You can combine them with the classic chemotherapeutics like anthracyclines and taxanes, specifically in patients who have stopped responding to or have shown poor responses to trastuzumab. You can also combine this drug with letrozole for the HER2/neu positive breast tumors as well. There is another version of trastuzumab called trastuzumab, and this basically, the brand name is shown there from Genentech. This is an adjuvant treatment to the HER2/neu early breast cancer that has residual disease, and this is really indicated for patients that have demonstrated taxane, a reduction in efficacy or response of the taxane and trastuzumab therapy. So this is unique in that it's the same trastuzumab molecule, but it's bound to a cytotoxic agent. And so from a mechanistic standpoint, we're not going to simply induce ADCC. We're going to dramatically induce ADCC with the antibody. And then once it's bound to the HER2/neu positive breast cancer cell, the cytotoxic agent, whether it's anthracycline or doxorubicin or paclitaxel, will also bind to that. And so it's more potent killing. These are the targeted therapies that have, sometimes they call them decorated antibodies or decorated molecules and so forth. They're basically an antibody bound to a chemotherapeutic drug. The side effects is basically the combination of the chemotherapeutic drug with the antibody. So fatigue, nausea, thrombocytopenia, and so forth. This is a nice summary diagram that shows the targeting of the HER2/neu. Let me slide the frame over. For some reason, it shifted a little bit. I had to stop the video for a moment to expand the frame. So I don't need you to know which binding site trastuzumab versus pertuzumab binds to. But for those of you who are visual learners, this is what this looks like. Here's the HER2/neu receptor, and pertuzumab and trastuzumab are binding to two different components on the HER2/neu protein. And of course, lapatinib is a small molecule inhibitor that's basically working at the intracellular level. Here's that RAS-MAP kinase pathway. And this is overly simplified. This isn't even probably an eighth of the pathway. But when RAS and RAF and some of these mTOR molecules and proteins become stimulated, the outcome is cell proliferation. And so this was cut from a nice review article. I believe it was in Nature, I can't remember. And here's basically the figure legend that goes with it. So these are the drugs that are available for HER2/neu positive breast tumors. And these are the drugs that can be combined with classic chemotherapeutic agents to offer very good clinical outcomes for these patients.